So, welcome to this afternoon's event where we're going to be talking about the End of Life Care Together initiative. My name is Penny Latin-Stewart and I'm delighted to have been asked to host this particular discussion for you. The whole idea of this afternoon is to talk about End of Life Care Together, remind ourselves why it came about, look at how it works in practice and the partnerships it's generated, plus put some kind of quantitative data to the anecdotal evidence about the difference the initiative is making to people's end-of-life experiences here in the Highlands. Then, the big question we want to ask of this afternoon is, what do we all need to do to convert early successes into long-term change? The afternoon is going to take the form of a panel discussion, where we're going to hear from some of the people directly involved, both in delivering end-of-life care together and who've been on the receiving end of it. After we've heard from the various panel members, who I'll introduce as we go along, there will be plenty of scope for your questions. So please do store them up, because we really do want you to be part of this conversation, and we're going to make sure there's plenty of room at the end to take those questions on. So, without further ado, let me turn first of all to Kenny. Kenny Steele is Chief Executive of the Highland Hospice. Kenny, I wonder if you can give us a quick overview of the background to how and why the End of Life Care Together initiative came about.
Okay, well, I shall provide a very quick overview. Initially, we're going to show a quick animation as well, a wee video that we've produced, which seems to manage to tell the story in 2 minutes when it takes me half an hour, so you'll be glad to know that I'll be passing over to the video in a moment. But essentially, I don't know anybody in our community who doesn't think it's a good idea to give people towards the end of their life the best possible life towards the end of that life. I suspect you've never spoken to anyone either that wouldn't think that's a very, very good idea. And that goes particularly actually for people who work within health and social care. We see it time and time again. People will go to the nth degree to support each other at end of life. However, we all know the stories of when it doesn't work well. And that's quite extraordinary, since as a population we all believe in this passionately. As a workforce we all believe in it passionately. So why so often doesn't it quite work? And the reason it doesn't quite work is that we don't quite work together as organisations to make it work. That's nobody's fault. It's a symptom of a system. But we also, I think we're all very aware of significant challenges to our health and social care system at the moment, and that's not just Highland, that's across the board. So we really desperately need to accelerate a shift in the system whereby we do all work far better together, where you get collaboration, magic will happen, where we can communicate better, people will get better care. So that's essentially, in a nutshell, why we've constructed the End of Life Care Together concept. Essentially though, End of Life Care Together is 20 organisations across the Highland that we have identified that all work within supporting people with palliative and end of life care. The reason we brought that partnership together is we've looked across the UK and internationally and looked at where does palliative and end of life care work well. And when I say working well, I mean where do we actually meet people's wishes at end of life? We know that most people would like to have as much of their care towards the end of their life in their own homes. Who wouldn't? That does not mean you do not require hospitals, you do not need other institutions. Of course you do. But people would like to limit their visits to hospital if that can be avoided and they can get their care at home. The only way you can change the system towards providing that is to work together. We know that from evidence elsewhere. We also know that it's really important that we identify people that may require support, palliative and life care towards the end of their lives. Because if we don't identify them, it's very hard to plan for the care. Now, we know that planned care is usually better quality care, it's better value care. Emergency admissions to hospital generally is not ideal in terms of quality, and it tends to be very expensive care. Now we're about to publish actually an accounting for value report, so we've looked at where do we spend most of our money caring for people towards the end of life. Now we've identified around about £45 million of expenditure annually on end-of-life care in the Highlands. We spend about 75% of that money in acute hospital care. Now most of that is absolutely appropriate spending, but we reckon about 20%, some might say 40%, I think conservatively about 20% of people are being admitted to hospital, and it's not because they need hospital, they need care, and often that care is not available locally in a responsive way. So they do end up in hospital, but it would rather not be, often become delayed discharges within hospital because we can't then discharge back to home because care services aren't there. And again, it's a symptom of our system that is happening, and all the organisations involved not being able to collaborate and coordinate the right care at the right time for people. So essentially, end-of-life care is trying to increase identification of people at end of life, coordinate that care, and provide the system around that will support people to be cared for at home for longer. So essentially, in a nutshell, that is end-of-life care together.
Okay. Could you explain a bit about the timeline of where we've got to within the past year, so where the services are at just now?
Yeah, no, well, past year, if we're honest, this has been going probably about 2.5 years, and again, trying to change the system, that's not going to happen overnight. I reckon you need at least 5 years to change any system, and we know, this system with health and social care is particularly complex. So we've done a lot of work in terms of partnership. Over the last year, we have put in place a 24/7 palliative care helpline. That's a key piece of the jigsaw. That provides people, both professionals and family, with direct access to expertise for palliative and end-of-life care. That's been put in place. What we have identified, which we didn't identify at the start of the programme, was a real gap in response to social care. So one of the key components that often people are admitted to hospital, it's just a lack of basic care. And it's not that basic care necessarily isn't there, it's just it needs to be responsive. We've got to create a situation where you can dial 999 and be conveyed to accident and emergency and enter hospital, just by lifting the phone. You need to be able to do that by lifting, to get social care. Nobody should really have to be admitted to hospital because of a lack of that. And again, we need to shift the way we work to ensure that responsive care is there. Now, we've been trialling a palliative care response service within Inverness over the last year. It's proved very successful. We've supported over 100 people to be cared for at home, where otherwise we think hospital admissions would have resulted. Now, care home is the lowest cost form of care that you can provide for people, and so it makes sense to make that end of the care responsive. We know that that's what people want, because it helps keep them at home, and we'll hear a bit more from Angela on that.
Okay. Well, what we're going to do now is play a short film so you can get a better sense of end-of-life care together working in practice and how it's made an impact on one particular family. This is Caroline's story, and it's told by her brother Ken and his wife Teresa.
Caroline, born and brought up in Fort William, and moved to Inverness 25 years ago. And goodness me, active, busy, independent, you name it, she was up for doing it. And sadly, about 2 years ago now, she was going through a phase of severe constipation amongst other things, and went to have that checked out, and discovered that there was a growth and a tumour down in her bowel. So that was a huge shock to her. There was hope that maybe we could see as much time through chemo as we could, but as it transpired, Caroline had about a year from diagnosis to passing away in December last year.
She was an incredible fighter, and at no point in any of that journey was she going to go without a fight. The idea that anybody else would have to look after her was abhorrent to her, to the point where it was actually quite difficult to talk about, end of life care, which was a conversation that certainly with her diagnosis and the way her treatment plans were going, I certainly felt that it was a conversation we needed to have, and it took a lot of care and time to have that conversation and to kind of say to her, look, if things do not go the way that you would like them to go, it's really important for Ken and I to know what it is you want from that last chapter of life, where you want that to be, what that looks like for you. And even at that stage, she was like, I just want to be able to look after myself as much as possible, but failing that, I really want to be at home. Nobody does fit a mould, for end of life care. Every single person is different. Their cancer journey is different. Their support network is different. I think the first call from Contrast Care, she's like, no, I don't need anything, and they were fantastic. And they said, that's absolutely fine. How about we just swing in and say hi and get a quick cup and just introduce ourselves? And so they were really gently, and through that trusting relationship, Caroline was eventually able to allow them to start to do little bits and pieces towards the end, which took a huge amount of pressure off of us and allowed me to be her sister-in-law, as opposed to bridging that, kind of crossing that line into to carer and kind of getting involved in her personal care. And it allowed us to kind of keep our relationships, and for me to enjoy being her sister-in-law in those last days and not her nurse. Phoning the palliative care helpline, you were phoning somebody that knew why you were phoning. You hadn't banged your toe, a sore head. You were phoning because it was, you were either really struggling to care for someone, or that person was really struggling. And you needed help, and so there was a great empathy, I think would be probably the best word to use, and a gentleness, and asking the right questions of us in order to make sure they had what they needed to get somebody out here to give Caroline what she needed. Caroline is the third woman in my life who unfortunately has passed away with cancer. One was my mum, and the other one was my stepmom. Now, all three of them, Caroline included, would have wanted to die at home. For varying reasons. My mum ended up dying in hospital, my stepmother died in the hospice, and Caroline died at home. Having experienced all three different scenarios when it comes to end of life care, for me and my journey with Caroline, and certainly for what I hoped for Ken, as he kind of nursed his sister and eventually had to say goodbye, none of them were easy. But being able to honour the wishes of someone who has quite clearly said to you in their journey through their care, through their cancer treatment, if this comes to the end, then I want to be at home. Being able to honour that and being supported to deliver that for her, I think has given us a healthier grieving process than I had with my mum and with my stepmom, because we couldn't change anything, we couldn't heal her, we couldn't keep her alive. So all that we had left that we could give her was what she asked for the end of her life, with the help of the external services that came and supported us to do that. And without them, I have absolutely no doubt in my head that Caroline would have died in hospital.
Me personally, why I think that the service is important is, one, it's given the immediate family peace of mind to know that there is professional backup that doesn't come with a standard package, if that makes sense, but is coming very bespoke to what is through that door. It's not somebody else's door, it's the fact you've got an independent lady there that is almost saying, I don't need this, but they don't go away and say, well, in that case then we can't offer you it. They're there just coming back again and again and again, just asking, what can we do, and creating that relationship.
This person is on their individual journey, and it is, it is their last journey. And we talk about good deaths and bad deaths. Surely all of us, whether we're professional or family or whatever, if we've got the wherewithal to give somebody a good death, then that's got to be worth. It's got to be worth so much. And for Caroline, she didn't want to die. She didn't have any choice though. So that's what was happening. To be able to give her what she wanted, not what somebody else thought was fit or what they had at the resources or but what she wanted and the way that she wanted it, so that she wasn't frustrated or angry or upset or offended, or met her where she was at. And everybody is completely different as to where they are at. Some people will want to die at home, some people will want to die in hospital, some people will want to. Everybody has their reasons for that, and having something that says, we're not going to make any assumptions here, we're just going to say, tell us what it is that you want and what support do you need, how do you want to see this play out, and we'll bring that to you. That's huge.
That was Ken and Teresa Keith. I'd like to bring in Gillian Carter. Gillian's a palliative care helpline nurse. Gillian, I wonder if you can give us a bit of sense of what that actually means day to day. What does your day look like?
I think just watching that video, you can just see what it's doing for patients and families. Essentially for us, it's rapid access to care at home and to support patients' end-of-life journey.
And so, give me a sense of how it actually works in practice. So someone like Caroline, Ken, Teresa, they're actually phoning you, and then what do you then go on and do?
So speak to the patient on the phone, but prior to speaking to a patient on the phone, you would look into past medical history, what's been happening, if there's like an out of hours plan, if they've got anticipatory care plan. You would look at all the notes first before phoning the family back, and then you call the family once you had all the information, and then quite often things have been escalated by patients at home and just need a wee bit of reassurance. All the calls can be quite varied, and then we either close a call off, or we would then hand it over to district nurses, GPs, for home visits, things like that.
So it's almost like a triage kind of role. And what kinds of people are calling? Is it the Carolines, or is it family members, or further, more people involved in care?
I think so. I actually work hospice and out of hours, so I've done the palliative care helpline for over 3 years now, and in my experience it tends to actually be family members that are calling. Patients aren't always able to make that call themselves, so it's normally family members, but the service obviously is becoming a bit more robust now, and so we now have calls from GPs, district nurses, care at home, Angela, and care homes and things like that as well. So it's getting the word out there.
And given it's that kind of broad spectrum of people who are contacting you, what kinds of issues are they coming to you with?
Which the issues are very varied as well. So sometimes it's quite an easy fix, it's more complex. So easy fixes would be patients that have maybe got a syringe driver set up at home, it's beeping, they don't know what to do, and we can quite often reset that over the phone. And obviously we can offer near me as well, which you will be able to see what's happening with the patient, and go from there. Simple medication guidance, and more often than not it's to give family reassurance and just let them have a chat. Complex care would be patients that have really had a kind of rapid decline in condition, things are happening really quickly, families are becoming a bit stressed, coming to crisis point, so there can be quite a lot of kind of follow up from that. And then obviously you've got patients who do actually need a visit, and if it was in hours, we would put it through to GPs, district nurses. Out of hours, it would go through to out of hours team, and essentially we've triaged those patients prior to them dealing with it, so they've got the full history there.
And how do you find the business of working via the phone? In the film, Teresa said that the helpline team had real empathy and knew how to ask the right questions.
Mm-hmm.
But I presume that's quite a shift for you from doing a lot of your work face-to-face to doing it over the phone. So how has that felt in practice? What has that meant?
I think, well, with COVID, I think everybody's had to kind of relearn how to do things. And obviously we have been taking phone calls, and so the biggest difference is that you can't see body language, you can't see facial expressions, and so you then start to kind of, zone in on what they're actually saying to you, and you can read between the lines. So, yeah.
It was interesting that I was just listening to the video fresh there, and they used the word, it was kind of almost a bespoke service and a real relationship that's formed.
Yeah.
And I get the impression then that you have felt able to form real genuine relationships with the people who are calling you, though.
I think, there's continuity. Quite a lot of the time you will get a lot of calls about a patient who is approaching the end of life fairly soon, and so you will have lots of contact with that family. You do build a rapport. When you phone them, you say, "Oh, it's Jill again," and they know that it's you. Also, we would say to patients as well, if we've had a few calls from them who say, "We're on all day," or "We're on all night," just give us a call back if there's any other issues. So they feel a bit more supported that way.
And from your point of view, although it is over the phone, which is a point of difference for you, how empowered do you feel or do you feel you're able to empower the people who are calling you to have the end-of-life care that they want? Do you feel they're able to, you can facilitate that over the phone?
Yeah, I think you just have to kind of listen to what they're asking. It's a different way of triaging patients. Obviously we're not seeing them, but they quite often will give you a good background as to what they need, and really it's all about kind of trying to support them in the community and make sure that they are at home, they're not reaching crisis point, and that they feel supported as well.
Last question. Doing great. Do you find it a rewarding role?
Absolutely, yeah, and actually seen a video like that. I actually only seen that video a couple of weeks ago, and I just thought, wow, because you don't really hear, we quite often have patients on the phone who say their loved ones passed away by that point, but they're still really grateful on the phone, and you do feel that you've made a difference then. But it was quite nice to hear and see videos like that, because then you do know that you are making a difference and it's impacting on patients' lives, so it's really rewarding that way.
Thanks, Julie. Well, the whole point of the initiative, as we've been hearing, is to bring together a number of different partners to work together. Angela Davidson, on my left here, is Director of Contrast Care, who we heard a little bit about in the film, and they've been working in partnership with the Palliative Care Helpline team as part of the whole End-of-Life Care Together initiative. I want to ask about contrast care, but before I do, we had a little chat before we came today, and I was so struck by how passionate you are about delivering the best end-of-life care possible. Why? Why does this matter so much to you?
When I first started on the initiative, I had a great passion because I had looked after my own mum at home, and I didn't have, it was difficult. I went through all that experiences that a lot of people are trying to manage at home. It was very, very difficult. Have a full-time job, think, how am I going to do this? You know, it was a very, very hard time for me, as it is for many, many people trying to support loved ones at home. So I was quite passionate when I'd first heard about the initiative that we wanted to be part of this and to give something back, if you like, to
change other people's experiences.
Yeah, and that passion has only grown, I have to say, over the past year, because I've witnessed firsthand how what huge difference it's making to people at home. I mean, we've been, like, when the nurses might phone and say, we have someone that's just been on the phone, they're really struggling, can you go around and visit them? We could be there within 2 hours, and what Kenny was saying about the 999, the quick response, some people need that there and then. And just, we've been met at the door with somebody just hugging us, that somebody's actually turned up to help them in that hour of need, and it's just so overwhelming to see that. And many stories I could give about people just being so grateful just to have somebody there to help them at that time. So yeah, it's just growing the passion for it.
So give me a bit more of a sense then. So call comes in, on my right here. And then Gillian might say to you, we've got someone who needs your help. How does it kind of then work? So tell me a bit about the kind of care that you're providing and how you come into all this.
So it might be there's a coordinator as well at the hospice who might phone and say we have somebody in the hospital who needs a discharge maybe in the next couple of days, or it could be to the extreme that somebody's phoned at the weekend and they've had a crisis point, as Jill said, and then they'll call us. They get all the information together and send a referral form to us. It's got really comprehensive information on it that we would need to go out and do our assessment. We will then make contact with the patient and or family, whichever is appropriate, and agree a time that's suitable for them to go and see them. Now that could be, like I say, immediately. We've done that many times, just gone round immediately. Or it could be the next day, or they could say, well, Monday's fine, or just whatever suits them, because it's their journey, it's what they need at the time. So then we'll go around, visit them, have a wee chat, see what it is they need, how we can help them. And we're quite autonomous in that we're allowed then to say, this is how many visits we think this person needs. We're not told. We make that decision with the nurses as well and the rest of the team. It's very much a team approach. So we'll say how many visits we need to do, how long we think we need to be there, and what we need to do when we are there. And we just continually feed back into the patient, the palliative care response service. And they've been amazing, really, and they're always there for us as well, and giving us advice and building our confidence. And so yeah, very much a team approach.
Now, although sometimes you get that hug at the door, which is fantastic, but as we heard in the film,
it's not always like that.
Yeah, so we heard in the film that Caroline was really resistant to help. So how do you deal with that kind of situation? Because that's a really difficult one.
Yeah.
Someone needs you but doesn't want you.
I know you
work. And I know you work directly with Caroline and her family. So how do you?
So it's knowing the boundaries, because everyone's different, as Ken and Teresa had said in the video there as well. Everyone is different, so it's gauging when you arrive. Well, Caroline was absolutely. We knew we weren't wanted, but it was just because it's not. We don't have to be there at certain times every day. We don't, we've got some flexibility there. So it was just chatting with Caroline. Totally understand. I wouldn't want it either. See, if I was in your position, I wouldn't be for me either. But we're not going to wait. No, it's more like, Caroline, let's come and see you. Maybe we can make a wee cup of tea one day, have a wee chat, and it was just building that relationship with her and building the trust until eventually, in fact, Ken had also asked us to do night calls, an evening call. Caroline, no way. So I said, well, can we phone you? Just to see how you are, that's all, just a wee chat. So those chats at night, trust was building again, and it was just, it all just came together in the end. That eventually you say, actually, I'm going to have a shower tonight, do you want to come round and stand outside the door? Yeah, I'd love to do that. So it's just, yeah.
Yeah, it's that word bespoke that kind of comes into my mind when I'm hearing you say that. And to what extent does the partnership approach and the fact that you're not just on your own there allow you as carers to make sort of better informed decisions on the ground? And how much you're able to tap into as well, the expertise provided by the hotline, because you said that you might get calls from people like
and we do. And the carers, it builds their confidence to know that there's a qualified nurse on the end of the line. And we'll sometimes go through the palliative care line because it makes a record for everyone to know that that call's taking place. But sometimes I'll be quite cheeky and just phone the mobile if it's just a wee query, you know, rather than having to go through the whole process. So we've built a relationship, I think it's fair to say, with the nurses, that we can ask them whatever we want. If we're not sure about something, we're quite happy just to ask that question. So it has built up that confidence. So because we are the ones with the patients all the time, so we're building that relationship, we're getting to know them, we're best placed really to see any fluctuations in their health and their well-being. So it could be something from like carer fatigue even, like we notice that the family are actually struggling, although they wouldn't be happy to tell anyone that. Or pain management, we maybe see a wee grimace or think, you know, we'd ask the questions about the pain, and that's when we would then go to the nurses and say they're maybe taking a little bit more breakthrough than they probably should be. So the nurse would then, just as a team, get somebody else out, the doctor out, the district nurses out to talk about pain management. Or carer fatigue, we might tap into Marie Curie to see if they can come out and help. And I think that's really important because it catches it early what could be a crisis and could be a hospital admission, but because we're there, we're noticing quite early, we're passing on to the nurses and they're getting the right people in to make sure that person can stay at home.
So it sounds like a real two-way street.
Definitely.
You're feeding out information from what you're seeing on the ground to the other partners involved.
Yeah.
So again, I asked the question of Jill about this business of how much she felt empowered to deliver people's end-of-life wishes. It sounds very much from what you're saying that you feel empowered, but is that fair? This has shifted for you. I mean, you feel...
Absolutely. I mean, we're there to promote independence. We're not there to take that away from anybody. And like in Caroline's case, for example, she wanted to do her own personal care. It's her choice, absolutely. We're there just to encourage her, to check that she's okay. If when she does get to that point where she needs our help, we're there. We're not there to take anything away from her. And it's the same with nutrition. It's the same with medication. Sometimes we can see when we arrive at the family are just overwhelmed by all the medication that's come home from the hospital, and so we'll talk through that with them. We'll go on to the nurses possibly to say, you know, can you talk through this medication because they're a little bit concerned about it, or the district nurse will be sent out. It's to empower them to then live their own life. We're there in the background, we're not there to take over until we're absolutely needed to do something. Yeah.
And the last kind of question on this, I wonder about, because you've got this partnership on the go and you're able to tap into the expertise of the helpline team, does that mean that in a sense your team are gaining new skills, are gaining more expertise, that there's a kind of growth in your knowledge?
Yeah, I've noticed from when we first started last November, I think it was, when we had Caroline, that we maybe ask less questions, or we're sort of, sometimes we phone up and say, this is what we think, what do you think? And they'll be like, yeah, or no. So yeah, we're definitely growing in confidence and noticing things that we may not have noticed when we first started. And again, that's coming from the nurses.
Because you formed a relationship with them as well. So it's that kind of a partnership too.
Yeah.
Thank you. So we know from talking to service users that End of Life Care Together initiative, it sounds to be having an impact from that film. Absolutely sounds to be having an impact. But what level of impact are we talking about? Do we have any concrete evidence when it comes to measuring the success of the service to this point? Well, Michael Lloyd here is Macmillan End of Life Care Together Partnership Director. Michael, let's kind of see if we can pin some figures onto some of this. But to begin with, remind us what you set out with in terms of what success would look like, because presumably you started out thinking, if we achieve that, that's going to be successful. So,
So I think really what we're looking at here is we've looked scoped across the country what models there are for delivery against palliative end-of-life care, and in reality there wasn't much measures against what happened within this population. If we think we measure things that happen within disease processes in other areas, but we haven't measured and understood what happens within this population. So taking a kind of realistic medicine approach or population approach or a value-based healthcare approach, we start to understand what the baseline is for people and what happens to people and how they die, how they die differently, where those kind of equities lie. But we also start to understand what their needs might be and what kind of resources people are using at end of life. We know that people are increasingly moving to a kind of medical model of dying and moving away from communities where we've supported dying in our communities, and that's skills that are getting lost in our communities. So it's not just this isn't healthcare. This isn't the responsibility of NHS Highland. We've all got responsibility in supporting people around death and dying. So it's about bringing those skills back in and about moving that cultural shift into being about supporting people at a social level around death and dying.
Okay. How many people, do we know how many people are currently accessing the service?
Yeah, so monthly at the moment there's 250 people a month coming through the palliative care helpline. We recognise that the out of hours element of that sits a little bit bigger. We've only just started the in-hours element since May this year, so that's kind of building, and from some service success from elsewhere we've seen that takes time to build and lots of communication around how to utilise that line, but generally the bigger periods of time in the out of hours period and weekends are really busy weekend periods for the team that are on the calls. See Joey nodding.
And are we able to kind of pin that number of people down? So we've got a certain number of people using it, but what does that mean in terms of impact on, say, hospital beds, hospital admissions? What's the figures involved?
So directly, if you look to the palliative care response services, you can see directly where people are discharged, you can see how that bed days would impact. And for the cost of social care for 2 weeks for a person, end of life, it would be less than a day and a half in hospital as an equivalent cost. But that's not really the focus of the programme. The focus of the programme is to bring better value, better outcomes to people in Highland who are dying and to their families. But just by doing that, we bring efficiency into the system, we use less resources. Kenny's talked about that 71% of spend that we know that's in acute. We know that spend is elsewhere, but we don't measure that very well. We know that only a third of people avoid a hospital admission in the last year of life, and 40% of people will have admission in the last month. And of those 40%, 3/4 of them will die in hospital on that admission. So actually this is a lot of the time driven to that crisis point, and that point I think reflects on what Angela's saying there. If we're not there to support them at an earlier stage, we can't recognise that to the point that they get a 999 call and conveyance into hospital. But where Angela's there, where the social care response, where there's resource there in our communities, we can start to look at that a bit differently.
I mean, it seems odd to talk in terms of finances and savings and things like that, and saved bed days or whatever else, because we're talking about human beings here, but it often does still, of course, have to come into this picture. So are we able to talk about this in terms of savings or number of bed days that have been saved, or is it about redistribution of funds? How do we put some figures on that?
We can talk about, we're not coming into this to make savings around this population so that we can do other things. Actually, we know from the numbers of people who are dying year on year that they're increasing, so actually there's more pressure on the service, but this is a third of people in our hospital beds in Rigmore or in our acute hospitals. This is 24% of our unscheduled care admissions. In Highland, we know this, so actually we should be having a really good understanding of how we support this population. And from that, from a value perspective, not value in terms of money, but value in terms of the outcomes for that person, value in terms of equity and how we deliver that to our communities, and value in terms of the resource that we use in Highland, we can start to look at this better, to say, this is the money we have to spend, not more money, because we know there isn't more money sitting in pots. We know that we're sitting in a difficult situation, and there's people in the room that will tell you how difficult that is. But can we spend that money better to meet those outcomes, and can we measure those outcomes for the person better? Rather than taking things from we often take things from research and evidence that will help us drive it's a recipe about how we might deliver healthcare, or from quality improvement where we look at pathways and processes. But this is about impacts and outcomes on the person and things that happen to the key family.
And the final question for the moment, do we have a sense of what the predicted future need is going to be for the services?
We have a 16% increase in people dying over the next 20 years. The complexity of that increasing. So we've got increasing people with lots of conditions, and we have lots of other challenges. We have lots of equity challenges. What the accounting for value of what we'll start to show is that where you live and where you die in Ireland depends on your postcode, but also what disease you have and those what deprivation status you have. So can we start to address those inequities as well through this programme of work to try and meet those needs? So it's not just about, it's about bringing impacts for families, but it's also bringing about equity across that population. And I think that the opportunity through end-of-life care together isn't to a project to see how things go. It's about bringing in a process and a culture and a programme of change that helps to understand and evaluate that on a constant level against the population. And that's kind of something we're going to do with the social science team.
Which was a perfect cue, wasn't it? So let's turn to Adam. We've heard about how end-of-life care together is impacting service users and staff. Michael's given us an idea of some of what we know about the data. Let's turn to that question of finance a bit more. We thought it would be really interesting for you to hear from Adam Swirsky. Adam is Chief Executive of Social Finance, who have been very involved in this. And we thought it would be interesting to hear a bit about why you decided to be involved. Before we do that, maybe you could explain a little bit about social finance as an organisation and where it comes into this.
Definitely, and really delighted to be here and be back in Inverness and have this opportunity to be with you today. Social Finance is a not-for-profit organisation. Our interest is in what we call lasting and widespread change in some of the most complex and enduring issues in society. So we work a lot across a lot of different issues, but we're really interested in how do you get those kind of changes to really take place in these kind of complex systems. And we have some of the tools. We work a lot with finance, with funding mechanisms. We know that's important. We also work with research and trying to find the best evidence with a lot with data as well. But what we know fundamentally when you work in complex issues is that the only way you're going to get change is if you work in partnership, which is our very core to our way of operating. But it's also why it's exciting to be this kind of event today, talking about how a partnership is actually going to drive change in a really important area. We've been working specifically, although we work on lots of issues, we've been working in end-of-life care since around 2015. It's exactly the kind of issue where you've got, it's complex to get right, but it's also hugely important for literally everyone. And it's also an area where obviously, as we've heard, we do spend a lot of money, but actually do we always spend it in the way that gets the best outcomes? And there's a real opportunity to think about how do you change the system to get better outcomes for people in end-of-life care.
So what is your involvement in this particular programme? Yeah.
So we've been involved in supporting the investment in this in these services, the palliative care response service and the helpline, and that's through a fund that we operate and manage with Macmillan, which is an end-of-life care investment fund, which is really designed to try and drive transformation in health systems that want to work in partnership to try and test different models to get better outcomes. So some of that investment, that investment is made available to local areas like here in Ireland, and then depending on the success of the service and the outcomes that we just heard from Michael around, then there's the ability for some of that to be repaid, which actually just allows that repayment to then go to invest in services elsewhere and kind of keep the transformation going.
And so what was the particular appeal of this partnership? What made you decide to get on board and get involved?
Yeah, I mean, we're hugely excited that that we're partnering here for a number of different reasons. I mean, first of all, with the Highland Hospital's Contrast Care, the end-of-life care together group, we've got really values aligned. We share really the same values, but also we can really sense the desire to innovate here as well, and that's what excites us. So we're really delighted to be partnering. I think in particular one of the big innovations, and it's really quite pioneering, is that this is the first social investment in health in Scotland. So I think you can get a sense for how the significance of what we're doing here and the kind of opportunity that it has. I mean, I think it goes without saying, but it's worth saying that these are some incredible organisations and services that we're investing in. And my colleagues Liz and Lorraine have been here yesterday and today, just talking with the teams and really sensing both the passion, which you could hear tonight, but also the outcomes that are actually being really achieved. And we heard that from Keith and Teresa as well. So we're a great set of services. And then the last thing is that we strongly believe that these opportunities are big opportunities for learning, and as well as being the first social investment in health in Scotland, coming to the Highlands, there's this big opportunity to see in this unique geography, this incredibly beautiful place, but also a really vast geography, that mix of the urban and rural side of it. There's a lot of opportunity to learn how do these services operate in that environment, and we can take that learning elsewhere.
Now, I talked a bit to Michael about parameters for success and how you define success, and I sort of bring the same question to you, because this is an investment. You've invested in something and you need to be able to measure that it's doing what you hoped it would do, but it's quite a difficult thing to measure, because there's a very utterly human element at the heart of this. So what makes you decide that this is successful and doing what you hoped it would do? How do you measure success for you?
Well, one of the things we think is really exciting about social investment is that a lot of the work goes in up front to make sure that we're all have the same vision for the kinds of outcomes that we're trying to achieve. And actually, it's one of the things in pulling a partnership together. There's one thing all agreeing that we're going to work together. There's another thing agreeing exactly what we're going to work together to achieve. And I think some of the things that Michael's talked about, we believe passionately that it's got to be a service that's good for the people that it's serving and for the system. And that's why we're always looking at are we achieving outcomes that really matter to the patients, to their families, to their carers, and are we ultimately meeting their preferences, having a good experience for them? But also, are we achieving some of the system goals? Because we know that one of the most important things is the sustainability of these services. We're really driving change in the system, and the system ultimately will respond to change if it believes that this is a better way of doing things overall.
I think I'm going to know the answer to this, but I'll ask it anyway. I wonder the extent to which the initiative so far has met with your expectations. How do you think it's going from where you sit?
Well, I think it is early days from an investment perspective, but I think it's hugely exciting. As I say, Liz and Lorraine have been here, and we're just sort of beaming with the energy that that they've been hearing from the teams, and we can I think hear it today as well. It's exactly the kind of service that we believe is really the right thing to do, and we can hear the experience so far on the ground. But obviously, we'll let the sort of data speak for itself. I think one of the things we really want to be able to show is that all of the positive stories that you're hearing today, we can actually demonstrate them to those in outside this room, and that is a core part of how we're going to achieve sustainability.
Thank you. Kenny, let me turn to you again and think about the future. I think we've heard loads of positive stuff today sitting up here, but what does the future look like for end-of-life care together? Where do we go from here? What do we need to go somewhere from here?
I wonder actually if it might be a good opportunity just to show the animation at this point. I think it's probably a good point now to bring it in as just a 2-minute recap on where are we meant to be going. So,
end-of-life care will affect most of us in our lifetimes. Across Highland, we're already delivering high-quality end-of-life care. We know the importance of giving someone a good death, and we strive to give people the care they want when it matters most. But we also know there are too many times when we can't deliver someone's wishes towards the end of their life. Sometimes the right care at the right time just isn't available. There can be many reasons for this, but too often it's because a person's wishes aren't communicated to all parts of the healthcare system. So we simply don't know what care will be needed and when. End of Life Care Together is a partnership of organisations across voluntary, health and social care, and we're committed to improving care towards the end of life for all. Most people want to be cared for at home wherever possible, but achieving this is complex at short notice, and when it's not possible, unnecessary emergency hospital admissions result. 1 in 3 hospital beds are occupied by people in their last year of life, but up to 40% of these admissions could have been avoided. This means too many people are dying where they don't want or need to be. We know more care could be delivered at home, but only if we all work together. If we increase identification of people in their last 12 months of life and understand how they want to be cared for, we can share this information with the health and social care providers who need it. With our centralised coordination and advisory service, we'll see where care is needed, coordinate that care, and reduce the need for unplanned hospital admissions. We know this will work because it's already working elsewhere in the UK. Positive change will take time, but working together, we will deliver the best possible end-of-life care for people in the Highlands. Be part of end-of-life care together. One person, one plan, one chance to get it right.
And again, back to, so that's what we're trying to do. What does this future look like? I mean, for me, the future looks like continuing doing what we're doing. For me, the future means working in this way. I just don't see an alternative. I think there's quite a lot of the time within health and social care, you'll hear the word pilot project. This is not a pilot. This is a new way of working. I don't think we have all the answers yet. We're seeing very good evidence that a central coordinated part of care helpline works. Access to responsive social care is an absolutely key ingredient. We didn't know that at the start. We know that now. We've demonstrated in Inverness. We need to ensure that there's responsive social care available to people at end of life across the Highlands. You'll often hear about the term specialist palliative care. So people often talk about hospices in relation to specialist palliative care. I think that's sometimes been part of the problem. Dare I say, hospices maybe have been part of the problem. We've been a part of a system. We can no longer afford to be a part of a system. We need to be the system. We need to remove the organisational boundaries between ourselves and look at what resources do we have that we can contribute to the system, because actually most of the resources are out there. Our partnership, particularly with primary care, is vital, and we've been getting a fantastic response actually from GPs across Highland. That needs to continue. So essentially the future looks like a partnership working future. We, as the hospice, put 1.5 million into a transformation fund for this. Social finance, very glad, came in with essentially another 1.5 million. So we have a £3 million fund, which in the bigger scheme of things, we've identified we're spending at least £45 million a year on end-of-life care. So 3 million doesn't sound a lot, but actually it's quite a lot to be able to sort of use to demonstrate things like palliative care line, response service, build evidence. Some of the things we might start, we won't continue because they're not the right solutions. But it's great having that pot of money, especially at the moment where money is very, very scarce in the public sector generally, particularly within the health and social care. It's an opportunity to use that fund to demonstrate a different way of working, and we will have to work in a different way if we are to support people with the quality we want to at end of life. As Michael says, the numbers of people dying within Highland and across Scotland are increasing because it's an older population. It's inevitable. So it's going to become a bigger part of our system, is caring for people at end of life. And if we want to do it well within the resources that we have available to us, we will have to continue changing.
You said there within the resources that we have available to us, so this isn't about finding new money, this is about sort of boxing clever with the money that we've got?
Absolutely. I mean, I'd be the last person to say I wouldn't like more money. But the reality, with it, particularly within our health and social care systems, that there is no new money. You know, it's certainly looking at the next 3 years. I don't think anyone is predicting that there's going to be more money within our public sector. It's actually probably going into slight reverse, which means we're going to have to be an awful lot smarter about the way we spend money. And I suppose that's, again, the point of our Accounting for Value report, is looking at, okay, where are we spending the money, and are we spending it wisely in the way that we as taxpayers want that money to be spent? I mean, do you wish to continue, you know, operating in this way where we're admitting people to hospital when it could be avoided, when we could be delivering better value healthcare closer to where people live? No, we definitely want to shift that money and spend it more wisely. Now, that is not easy to achieve. It's these things sometimes sound simple when you talk them out loud, but that is not an easy thing to do. And you know, we're working very closely with partners in NHS Highland. I mean, to be fair, NHS Highland is leading the way in Scotland. We were meeting with Jenny Minto, MSP, who's the Minister for Palliative Care, and talking to her just this week about End of Life Care Together. She was very excited about what's happening in Highland, because she's not seeing this way of working in other health boards in Scotland. I think, you know, NHS Highland deserve an awful lot of credit for that. They have identified palliative end of life care within their strategy. That ambition in their strategy is called End Well. We haven't seen another health board in Scotland that has prioritised palliative end of life care in the same way as NHS Highland has, and also prioritised doing it in partnership on a population-based approach. So I think we are breaking ground in Highland, and I think the Scottish Government is very interested in, you know, is this a model for Scotland? Because I think they recognise, you know, this is a growing issue. How do we care for our population at end of life, especially within a system where our hospitals probably aren't the place that are going to be able to take that additional need.
We've heard lots of really positive stuff today, but you know, no system is perfect. No, you know, everything is always evolving and changing and growing, and you know, from your point of view, where would you like to see this develop further? Are there any particular blockages or things that you wish we could be doing better, even with, you know, taking into account the stuff that we've done to this point, which sounds very successful?
It does, but you'll always hear the successes, won't you? Where we haven't succeeded is digitally. Now, at the outset, we recognised, and again, where we've looked across the UK and internationally, where have people done better than we are doing? And they have always had a digital system that communicates across organisations. Now, it's all very well saying we'll work in partnership. If we can't communicate together, then that's a challenge. So, and we ask GPs, you know, why don't you do more identification of patients you think are end of life? And why don't you do fully comprehensive care plans? And what we often hear is, well, why would we? Because nobody can see them. You know, if we in primary care are the only people that can see these plans, well, we already know what our patients need. But it's when those patients then go into the care of another part of the service, then if those people can't see the care plans, so for example, when people phone our palliative care helpline, I would like to be able to see us go, okay, yep, we know who you are, okay, yes, your GP has identified you, we can see the care plan, we can see what's important to you, okay, we don't need to ask a million questions about you because we know all about you. But also, if we're giving any advice, we can put some notes. And in the morning, the GP will be able to see, okay, they phoned the palliative care helpline last night, you know, this is what's happened. When an ambulance does get called, because ambulances occasionally will need to be called, they'll be able to see, right, okay, that your wishes are you wish to be kept at home if at all possible. Okay, that maybe changes our judgment on whether we should take you to hospital because we weren't sure if we were going to or not. Oh, now we know that your wishes are to really stay at home if at all possible. And maybe we'll just call the palliative care helpline. If you know, see if you know about this patient. Yes, we do. Yes, let's do this to keep them at home. And at the moment, we don't have a way of communicating those wishes across the system. And again, that was actually partly our discussion with Jenny Minto, MSP, this week, because she also has responsibility for digital health. We believe, and it's what the Scottish Government wants to achieve, we believe we have an opportunity to test doing that in Highland, having a single patient record that we could share across the system. Let us test it. Let's test the system like that in Highland. And then again, in fairness to NHS Highland, Ian Ross with eHealth is really enthusiastic about doing that, but for certain extent, we don't want to go off in a direction in Highland that isn't the direction that we're going to go off in the rest of Scotland. But again, we would like to see something tested in Highland that actually could be a solution for the rest of Scotland. So that's a frustration that we haven't moved more further forward with that, because for us, that's when the real magic will start happening. You know, that will add a lot of value to what we've already built.
It's perhaps naive of me, but I'm kind of surprised at that. I mean, it sounds like something, given today's tech, that should be relatively easy, but clearly it isn't. Michael, is there anything you wanted to add in that before we open up to questions?
No, it's complex, but that digital shared care plan is really important, because actually we talked a lot about healthcare usage, but how does somebody have their say in what they want? So we as clinicians can be very paternalistic and decide what people want in their care plan, but we're increasingly recognising the need for shared decision making and having that point where it isn't just about biomedical information, it's about biographical. So what matters to me and you about what you want, so that we can make a shared decision about where we want to go and where we don't want to go. And that makes it the easier decision making for ambulance service carers sitting there, for the carers, what do they do if somebody wants to be escalated up? Can that person share that care plan? And actually, should they be in receipt of their care plans? And I think really I'm working with Scottish Government and the team around looking at future care plan and delivering future care plans sits within that same policy team. And we started 2 weeks ago, and the primary aim of that group was to enable citizens to hold their own records and be able to see their own records. So actually their quality assuring the information that's coming from clinicians to go back out again. So it's really important to enable this work, but it also provides us data about what people want, where people want to be and how, so that starts to make us understand the system better. So we know we've got the ability to do that, we know we've got the technical mechanism to do that, but we need to trial it and deliver it. And I think, as Kenny says, we can't do that in isolation. We need to do that to keep the kind of resilience or robust delivery of that with at a national level. But we have the opportunity, I think, with the vehicle that we have here, and this is what we're speaking to, not just Jenny Minto, but the leads in NES and in the Scottish Government from the policy team, is about help trying to provide a vehicle to deliver this against.
I think we're probably at the point of wrapping this up. We've got a few more minutes where you can get another coffee, have another sweet treat if there's any left there, and continue the conversation sort of more informally. But I would like to thank you all very much for coming and for giving us your ears. I'd like to thank the panel as well: Kenny Steele, Gillian Carter, Angela Davidson, Adam Swirsky and Michael Lloyd. I want to leave you with Theresa Keith's closing words, which reflected on the value of being able to give someone what she called a good death. She said, having something which says, tell us what it is that you want and what support you need, how you want to see this play out, and we'll bring that to you. That's huge. And I think that is huge. I hope you found it thought-provoking and useful discussion. Thank you very much indeed.